Taking the time to be here tonight. And thank you for answering the registration question. We have a great group of professionals, and we have a very large group of professionals from the entire United States. Thank you for joining the War on Dental Waterline Biofilms, 5 Strategies for Water Health. In order to receive your CEU, you must be active in 3 polls and answer the evaluation immediately following the webinar. Once I close the webinar, the evaluation will pop up. You will receive your CEU within 14 days or by Thanksgiving. If you don't, please email me. Check your email for the Waterline reference chart. I sent them out this week. If you haven't received it, please email me. Any of the addresses ending in edu came back to me, so I will need a different email address for all of you. Questions and answers will be at the end. If we don't get to it, all of them tonight, I'll place them on my website in approximately 2 weeks. So let's get started. My name is Pat Pine. I'm your speaker tonight. I'm a dental hygienist, a speaker trainer on a variety of dental topics. I provide hands-on OSHA and infection control in the dental community. I've been guiding offices for 14 years on the correct protocol and guidelines in infection control and OSHA compliance. Look for another webinar in March on dissecting disinfectants. Please spread the word. The more the merrier. We all learn from each other. Now, I would like to ask you to all of you get up out of your chairs, shake your hands out, and do 3 jumping jacks. 1, 2, 3. Great. This is getting the blood flowing because you've worked all day and you're probably tired. This is the hands-on portion of the boot camp. Just kidding. Biofilm will be continuous. The war on biofilm will be never-ending. Biofilm changes its shape, character, and is immune to antibiotics. Dental professionals are the first line of defense. We have many options of ammunition to help prevent our team and our patients from getting ill. Now, we are talking about dental unit waterline biofilm. We're not talking about evacuation systems. So please don't drown. Stay afloat with me. We have the ammunition for this battle. I want to thank our sponsors for making this webinar happen. These sponsors are very important to Waterline Health, so don't hesitate to contact them with any questions, instructions, or anything you might need. My disclosure is that this is an educational webinar, not a sales program. This is for your information and convenience. Each review is given to my honest opinion, and I put in a lot of time and dedication for research and providing information as well as ideas. Compensation received will never influence opinions, recommendations, or speaking content. So let's go to poll number 1. We're going to have 15 seconds. I'm going to launch this poll, and this kind of tells me where everybody's at. So what is the recommended CFUs for dental unit water quality? So go ahead and click on which one you believe it should be. Okay, we're going to go ahead and close that poll. The answer is D, less than 500 CFUs per milliliter. Now, drinking water must be at least less than 500 CFUs, so our dental water lines are recommended less than 500 CFUs. The quality of dental unit water is of great importance since patients and dental staff are regularly exposed to water from aerosols generated during work. The dental unit waterline contamination has become a concern. Biofilms are natural occurrence in the aquatic environment, including community drinking water systems. The interior of small diameter tubing in the dental unit waterlines are also sites of biofilm formation. It's the size of the tubing and the flow is minimal and progressively decreases to the status at the interior wall surface of the tubing. We wouldn't knowingly drink dirty water. Now, safe water guidelines come from the CDC, the ADA, the EPA, OSAP, the American Public Health Association, the American Water Works Association. And the ADA statement was to manufacturers of dental units in 1995. They had requested that the dental manufacturers reconfigure our dental units for the safety of our water lines. And that was in 1995 that they had a formal statement. And the manufacturers had 5 years to improve dental equipment. In 2003, the Centers of Disease Control guidelines for infection control in dental health care settings was less than 500 CFUs. Currently, there must be under 500 CFUs per milliliter, which is the standard for drinking water. The CDC has recognized that there is a waterline concern. So keep looking for changes. There will be some ahead. Understanding and recognizing the risk of disease transmission is because we're trying to reduce the liability of the dentist, the patient's illness, employee illness, and doctor's health. Dentists can no longer pretend that there is only a theoretical problem. Now that the state-of-the-art has illuminated dental water contamination as a potential health risk, dentists must acknowledge the problem, stay abreast of the rapidly evolving standard of care, and do their best to comply with the standard of care in daily practice. If one of your patients becomes ill as a result of an exposure to a pathogen or bacteria that is later found in your dental unit water, you are at risk of being held responsible for the patient's illness and associated compensatory damages, and your reputation. Biofilm can cause disease. Biofilm is sticky with a mind of its own. It has changing characteristics and can be very harmful to the human body. What is your baseline? What are your CFUs? World News, in February 2012, an 82-year-old woman died from the dental unit waterline. The dental community is high alert after this situation. This situation was related to Legionnaire's disease, a life-threatening type of pneumonia caused by Legionella bacteria, which she acquired while receiving dental care. The elderly woman was hospitalized after becoming ill with a fever and respiratory distress. After chest x-rays revealed lung consolidation, the patient tested positive for Legionella pneumonia and was promptly diagnosed with Legionnaire's disease. Despite medical efforts, the patient died 2 days later, and an investigation into the source of the bacterial infection was launched. Because the patient had left her house only twice over the prior 2-week period to seek dental care, it was clear that the infection originated from either the dental office or her home. Samples taken from the dental office's tap and high-speed dental turbine contained positive traces of Legionella, while the samples obtained from the woman's home were negative. Legionella pneumonia is most infectious when inhaled from aerosolized water, such as that created by the high-speed dental turbines. Once inhaled, this contaminated water has the potential to cause Legionnaire's disease, especially among people with compromised immune systems. Chicago, 2012, 8 patrons from the Marriott Hotel contracted Legionnaire's disease. 3 died. They have discovered Legionnaire's disease in the fountain in the foyer of the hotel. Illinois, 2005, you'll have to wait for that because it's in the article in January RDH magazine. And you'll look for hidden water danger is the name of the article. California reported a dentist that died from Legionella disease from his own dental water lines. Legionella was named after the 1976 Philadelphia Convention. It was the air conditioning units. 8,000 to 18,000 people are hospitalized per year with Legionnaire's disease pneumonia. The convention killed 20 men, and 110 were very ill from Legionnaire's disease. Studies have demonstrated that the dental unit water line, the narrow bore plastic tubing that carries water to the high-speed handpiece or air water syringe and ultrasonic scaler, can become colonized and with microorganisms protected by the polysaccharide slime layer known as the glycocolate. These microorganisms colonize and replicate on the interior surface of the waterline tubing, which serves as a reservoir that can amplify bacterial growth. So we're going to talk actually about 6 strategies: the patient's health and team health, standard operating procedures, how to monitor manufacturer's directions, training, and scheduling. Strategy 1, patient health. The health history is our best source to determine if patients are at high risk. Anyone on medication is a risk. Anyone with diabetes or heart disease is at risk. As dentistry should be recreating a health history that links our physical and oral health, this is something that will be in the future. But we as dental professionals need to ask open-ended questions. Updating the medical history is so valuable and important. Then we have AOSH, the American Academy of Oral Systemic Health.org, AAOSH.org, is a group of professionals, cardiologists, and dentists that are working together to get a health history for that connection. Clinical implications. Well, patients trust we are doing the right thing. They don't know what we're doing behind the scenes, but we also want to prevent cross-contamination and disease transmission. This is why we have OSHA, and we have infection control guidelines to keep everybody healthy. But some patients don't know if they have compromised health or not. So we need to ask open-ended questions and get to the bottom of their health. Some patients don't care to answer some of our questions, but we need to convince them that there is a link for oral and physical health. Oral health care workers and our patients, we all sit within 3 to 4 foot radius. We have Pseudomonas, Calbesia, Legionella, and non-tuberculosis mycobacterium that are leaching out at us with the aerosols in the air. So we need to be sure that we are wearing our masks correctly and that we're wearing the correct PPE to help prevent any disease transmission. So what are we spraying on our patients? You think of our metal syringe tips, there's no way we can clean those. There's no way to get the bacteria out of the inside. And with this photo from Total Care, we can see that the bacteria is lining up inside the walls of the metal syringe tip. The CDC strongly recommends a single-use disposable air-water syringe tip. This way, we know for sure that we cannot transmit disease. And look at this picture. Check this out. Where are all the aerosols landing? Years ago, we didn't know what we didn't know. But the study from the University of North Carolina School of Dentistry found that 1 out of every 5 bib chains tested were contaminated with bacteria. The bacteria is all falling all over the patient's neck and the bib chains. They were actually cross-contaminating one patient to the next. I have an article on my website, what are you hanging around your patient's neck? And we sometimes don't know what pathogens are lurching on these bib chains. But we want to say a big thank you to Ducks Dental for the 4th annual Bibbies for Boobies campaign. Ducks Dental donated $7,500 to Mammograms in Action, which is a nonprofit breast cancer center for low-income and uninsured women. And the donation was from dental offices donating their contaminated bib holders in exchange for disposable bibbies. They gave $5 for each contaminated bib holder. So we thank you, Ducks Dental, for the fight of breast cancer. This is what the study showed, is that we have blood, E. coli, dead skin, MRSA, saliva, strep, staph, Legionella, and Mycobacterium on our bib holders. So I wouldn't want to put that around somebody's neck, and I wouldn't want it around my neck. So this is a decision that you need to make, but disposable is in. Choice of mask. If we know that the average Legionella cell is 0.5 to 1.0 micrometer wide and 1.0 to 3.0 micrometers long, where are we with our masks? Are we safe? Are our masks protecting us? Because it's the cheapest mask in the catalog doesn't mean it's the safest mask. There was a recent study found that the tighter fitting mask may provide more than 100 times greater protection against infection than a loose fitting mask. Will your mask protect you? And I just want to say that if you're wearing your mask under your nose, you're not protecting your upper respiratory system. And if you're placing your mask on your neck instead of taking it off, you are now contaminating your neck and your PPE with all those bacteria. And you might be taking them home to your children. So you definitely, if you're going to take your mask off, just take it off. Don't place it around your neck. Why the concern? Well, if we have poor water quality, we have aerosols that are plethora around the room. And the aerosols within the dental operatory are so plentiful. Studies show that the 3 to 4 foot radius of bacteria is not only coming from the high-speed handpiece, but it's the patient's oral bacteria, caries bacteria, periodontal disease bacteria, and this bacteria all enters the patient's oral cavity. Scaly and root planing can be called an open wound on some. So we really need to be careful that we are not secondarily infecting our patients. So we need to break that chain of infection and reduce the number of organisms in the clinical environment, which would be to maintain our water line. We have poll question number 2. What is the main concern? Let me get it up there. What is the main concern with dental unit water lines? We have 15 seconds. Okay, I'm going to close the poll. Thank you. Great. Answer is letter C, quantity of colony-forming units. If you have a different answer, you might want to email me, but we can talk. Quantity of colony-forming units is what we're checking with the dental unit water lines. What is biofilm? Biofilm is a community of bacterial cells and other microbes that adhere to surfaces and form a protective slime layer found in virtually all places where moisture meets a suitable solid surface. Biofilm can contain many types of bacteria as well as fungi, algae, protozoa, and nematodes. The polysaccharide slime produced by many microbial inhabitants protects the cells from physical and chemical challenges, while water channels within the biofilm carry nutrients to the cells inside the film. Individual organisms or even portions of the biofilm near the surface break off into flowing water. In dental water lines, this can result in contaminated coolant and irrigating solutions. Sounds similar to arteries and cholesterol. Biofilm is everywhere where moisture is present. It's in our drinking water, it's in our showers, it's in our hoses, and anything else that might be moist. You may find some of these pictures disturbing. The biofilm inside within the tubing is similar to the arteries clogged with plaque. The upper left is the tubing with the biofilm. Look at how thick that is. We have a very thin flow of water. The upper right is the stream of water with biofilm. This is slime that is present on the rocks, wherever moisture is present. The lower right, we're all aware of this biofilm. This is plaque, and it causes gingivitis and perio disease. The lower left is a filter that is covered with biofilm, the reason to continually clean filters in air conditioners and dehumidifiers. Now here are the stages of biofilm development. Stage 1 is the initial attachment. Stage 2 is irreversible attachment. Think of superglue. Stage 3 is the maturation 1, where it's just beginning to grow, get thicker. Stage 4 is maturation 2, where it's made its columns, it's made its tower. Stage 5 is, I call the castle, and it's dispersion of more biofilm where it's growing. So the slimes producing bacterial communities that may also harbor fungi, algae. These microorganisms colonize and replicate on the interior surfaces of waterline tubing, creating an adherent microbial accumulation. This biofilm is not going to give up easily. Biofilm is not our friend. Here's the biofilm that's showing you how the water flows and gives its nutrients, its oxygen, its ventilation, plumbing, nourishment, communication, modes of travel, and the armor of protection, slime. Periodontal disease also has biofilm in its matrix, and antibiotics cannot attack the biofilm because of the slime protective layer. So we have the ventilation system, we have the waste system in the water. So if your water bottles smell, it could be because of the E. coli coming from this bacteria and this biofilm. Like periodontal disease, biofilm, it's like poop in the sulcus. This is what the biofilm does, and this is why your patients have very bad odors. Communication is quorum sensing, the bacteria talking to each other. Here's the slime. It grows very quickly in water systems. The planktonic cells flowing in the water clot together and form a layer of sessile cells, which attach to the inner walls of the tubes and pipes. Colonies are growing very rapidly and attract some more planktonic cells. The slime can grow and block free water flow and forms a contamination which is a hazard for water quality. And when you think about it, we have MRSA, bed sores, and osteonecrosis. These all have a slime layer that antibiotics will not help. So biofilm is not our friend. It is our enemy. Who lives in the dental water lines? We have Mycobacterium, Pseudomonas, Legionella, and Staphylococcus. Now this is my personal experience with biofilm. If you see on the slide, my biofilm that came out of my Cavitron scaler, the handpiece. And this is something I never expected to happen. But using the Cavitron, we always need to bleed the lines, which means to bring water to the top of the handpiece and then insert my Cavitron tip. I started using it and the insert popped out. Well, pulling it out, bled the line again, placed the insert, used it for approximately 5 minutes. The insert popped out again. I couldn't figure out what was going on. I figured there was air in the line. The third time I was using the Cavitron on the same patient, and the insert popped out, and this came out with it. Little did I know this was lurking in my water lines or my handpiece. Of course, I stopped using this piece of equipment. This equipment was attached to a municipal water source. Never did we have a connection to flush the lines. This facility was over 40 years old. Little did I know what was in this water line. Here is a Q-tip that I used to remove biofilm from an uptake straw. The uptake straw was pretty black, and I didn't like that color, so I decided to remove it. This is mold, mildew, and biofilm. So if you have a black bottle or a black uptake straw, you definitely need to replace them. Bleaching them out will not totally remove the biofilm. So this is my joke for the evening. I just can't go with the flow anymore. I've been thinking about joining a biofilm. Biofilms are gangs. They're not fun. They are destroying our water lines, and it causes for a very unhealthy environment. And biofilm can destroy our equipment and can cost a lot of money. So biofilm is tenacious and will not let go easily. This is why it's so important to systematically keep up with your water maintenance and water testing. We don't know what we don't know, but we do now. The water tubing inside the thin tubes used in our dental operatories play a prominent role. The biofilm is tightly bound to the lining of the dental unit water line tubing, and the high surface area to volume ratio increases the area accessible to the development of biofilms. Most plastic dental tubing has an inside diameter of a 1/16 of an inch and is made of polyurethane. This form of plastic does not, biofilm adheres to very easily. And this thin tubing is also the reason diluted bleach is not recommended, because it's very caustic and does not do well with plastic polyurethane tubing. Bleach does kill just about every germ or pathogen, but it's also very, very harmful to our dental equipment. Strategy number 2 is standard operating procedures, and they will assist in training current, new, and future team members. The set of written instructions that document routine or repetitive activity for the group or the team. SLPs provide a system for individuals to perform a task or job properly with quality and integrity, and it facilitates consistency. There's no doubt on your waterline protocol if it's written down. Quality starts with training and manufacturer's direction. Clean first. Isn't this one of the #1 infection control rules, is clean everything first? As with cleaning our dishes at home, we always rinse them out and then put them into the dishwasher. Well, the same thing is before we glove, we have to wash our hands. Before we sterilize, we clean our instruments in the ultrasonic. And environmental surfaces, we clean before we disinfect. The same thing with our water bottle between patients. Are we wiping down that water bottle like we wipe everything else down? First to clean, second to disinfect. The environmental surfaces should be cleaned prior to disinfecting. The proliferation of biofilm is normal, but we must control it with routine maintenance. Our daily protocol is what type of water is being used, tap, distilled, or sterile. At the beginning of the day, there's no need to flush the lines. Flushing lines at the beginning of the day has been proven not to be helpful in removing the biofilm, because the biofilm is firmly adhered to the inside of the water tubing, and it does not dislodge by flushing for 20 to 30 seconds. But flushing lines between patients is recommended to remove any possible suck back in the lines. You also need to make sure your anti-retraction valves are there and maintained on every single dental unit, even if your unit's over 20 years old. The anti-retraction valves help prevent backwash from the previous patient, which also brings up a topic of our saliva ejectors. Please, please, please do not ask your patients to close their mouth over a saliva ejector, because they can get backwash from the previous patient, even if you flush it with water. They are recommending a saliva ejector that has a valve, and they're all disposable, and that valve prevents any backwash from the previous patient. And those are safeflow.com. And if you have any questions on there, you can contact me later or email me, and I can give you more information. Daily routine is, of course, infection control practices. We wash our hands. We put on our PPE. We need to wipe down the outside of our water bottle and wipe the connections. You can use a 2x2 with alcohol on it to reduce the contaminants, and also the threads on the bottle. Now, I'm not real comfortable with the picture on the upper right, because I don't know who has touched the threads of the bottle on either bottle, And that's one way to cross-contaminate. And although we're not looking for sterile water, we're looking for clean water that doesn't have an overabundance of colony-forming units. So I would suggest that you purchase a stainless steel funnel and sterilize that in a pouch and have 2 of those in each operatory. Also the straw, you do not want to touch the straw because you would be contaminating it with your hands. And then you can also use a 2x2 alcohol wipe for that straw just to reduce the bacteria count that might be on it. And we want to refill our bottle with quality water using a stainless steel funnel, and then place our product, this happens to be a tablet, and place it on the unit and physically clean regularly. Fill her up. We need 1 inch of air space. So don't fill your water all the way to the top because we need the air pressurized in these bottles. But size does matter. Look at the bottle on the far left. It is larger than the one on the right. And we need to check with the product manufacturer the size of the bottle and the tablets or the liquid needed. So the largest bottle on the left might need 2 tablets, and the one on the far right might just need 1, or the far bottle on the left might need 3 tablets. So you need to determine with the manufacturer how much product you need in the size bottle that you are using. It is all about the water, but it's also about the geographic location that makes a difference. Going from Chicago to Arizona, we didn't have the hard water in Chicago that we have here in Arizona. There is a lot of calcium and contaminants in our Arizona water. The tap water is much harder. We also can purchase our water distilled, and then we can also make distilled water. Any large dental or medical facility might consider purchasing an industrial-sized distiller so that you can make your own water. Purchasing it is fine. There are just many other options out there. At the end of the day, what do? Do we shock our lines? Do we purge our lines? Do we let the bottles dry out overnight? This is all going to depend on your product that you are using because every product is different. So my recommendation is to get the instructions of your product and laminate it and keep it in each room so everybody knows what to do. Now, I'm not comfortable with this photo right here with the water bottles sitting right next to the sharps container in the garbage. People throw things into the garbage, and now we have a lot of bacteria floating around these water bottles. And then at night, we have the heat or the air conditioning going on that is circulating more bacteria and that could be entering these bottles, and you think the bottles are clean. So my suggestion would be to keep the bottles away from any garbage. We shouldn't be storing anything under the sink or where garbage is present anyway because it contaminates everything. And then I had a question about mouthwash. Can we put mouthwash in our water bottles? I do not recommend mouthwash because this can create a very sticky situation. And the biofilm would love it because that would be nutrients for them. And it's a very sticky substance on the inside lining of our tubing. So no, I do not. I would look for a product that maybe has a flavor in it, but I would not put mouthwash into the water bottles. Night air purging. Well, studies have shown that it's not necessary, but more importantly, you need to treat the dental unit itself. Sometimes a once-a-week product will say empty the bottle and dry the lines via purging. Some products are continuous use, so they don't want you to take those bottles off and create bacteria on the lines. And don't forget that when you take those bottles off at night, you have a naked straw, and that straw can become contaminated from the cleaning people or just the aerosols in the air. So I would really consider twice, I'd really reconsider taking those bottles off at night. But you need to use the product that meets the needs of the practice and definitely go by according to their directions. More guidelines. Well, we want to follow the ADA CDC guidelines. We want to flush the air, water, syringe, and hand pieces between patients. We definitely want anti-retraction valves installed and maintain them. Do not heat your water. When you heat water, put hot or warm water in your water bottles, which is really for the comfort of the patient, you are actually encouraging biofilm growth. Because they think that's a spa. They just think you just did this for them. So that is going to multiply the quantity of bacteria in your water line. Distilled water is not sterile water, and no matter what product used, this does not exclude any periodic cleaning of the water lines. So no matter what product it is, you still need to periodically clean them and test quarterly. Okay, so what happens on the weekends when you're away from work and this bacteria is sitting in your water lines? Well, bacteria populations double every 20 minutes. So at 8 a.m., 1 bacteria. At 12 noon, we have 4,096 bacteria. And at 5 o'clock, we have 134 million bacteria. So this is untreated water that is left stagnant at room temperature. And this is an overabundance of bacteria, which is at risk for transmission of disease. And what about those swing rooms that you don't even use every day? Weekends, holidays, that water turns stagnant. It would be advisable to shock your lines before these holidays and weekends, and definitely those units that are not in use. But we must test all the rooms. We cannot just monitor one operatory. We have to monitor them all. And we have to monitor all the tubings. We have to monitor the high-speed handpiece, both, or if you have 2 water syringe tips or a water syringe, you need to test both of those. You need to test everything that has a water tubing in it. So here's the strategy of monitoring the water quality. We need to test our dental unit water lines. We need to test them quarterly. We have to use absolute asepsis. We need a maintenance chart so we know who's doing it, because they're going to initial that, and we need to stay on top of that and find out what the results of the quality of our water are. Water line testing, well, this is critical, and this can be done in the office. You can in-office testing and then send it out to an outside source for the results, or you can use a local lab in your vicinity. But what you're checking for is the CFUs. You want to know how many colony-forming units you have in your dental unit water line. So when you simply collect a water sample from each dental unit in a separate test vial or test tube, then it's placed in a provided mailer. So you kind of want to do this on a Monday because you want them to receive your water line. Some of them include ice packs, so that the water stays cool, and then so they get it before they leave for the weekend also. So check the instructions on your water testing service. So we were testing the quality of the water. We're testing if the product is effective. How do we know the product we've used for 5 years is really working, but we have black tubing, and we have the black uptake straw, and we have the black bottle. So we definitely want to make sure that our dental handpieces are tested. And according to the United States Air Force on water lines, the monitoring of your water lines should be quarterly. When testing all water lines in each room, if they do not meet the CDC and the ADA standards of less than 500 CFUs, you must shock each line and retest for 3 months. So each month for 3 months. When you receive the under 500 CFUs, you can go back to testing quarterly. But you do not want to test immediately after you've done a shock treatment, because that would give you a false sense of security. So you definitely want to test your lines. If they come back with a greater than 500 CFUs, you want to shock them, or you want to test them every month for the next 3 months after you've shocked them. Cleaning and shock, well, by manufacturer's directions. and we want to, whatever product we've selected, we want to go by their directions. We want to make sure it's compatible with your dental unit. And, you know, there's time limitations on all of this. So you need to be sure that you have your office, your team has the time. And I am a strong believer in tagging your units if you're leaving them overnight or over the weekend. Because what if somebody calls in sick on Monday morning and somebody needs to go flush those lines? This way there's a big red tag on there saying do not use flush the lines. It would be very hazardous for a patient to receive contaminated shock water. That could make them very, very sick. So be sure that you've got some sort of system. You can create a sign, laminate it, and each operatory has this, and then you tag the unit before you leave if you're going to head and cleaning or shocking the lines. When to shock your water lines? Well, definitely by the manufacturer's directions and quarterly. If you have a discolored bottle or uptake straw, you know something's going wrong in your water, with the quality of your water. So that would be a great way to know that, hey, maybe we haven't shocked the lines lately. But that's why we want to keep it monitored and keep it on a schedule. And as I said earlier, if the CFUs are greater than 500, then you have to test monthly for 3 months. Once the CFUs are below the 500, then we can go back to testing quarterly. Black is not in, nor is it healthy. Mold, mildew, biofilm, that's dangerous. And also, are those clean hands that person's using? Because what we're doing is if we touch that straw, we're cross-contaminating. And so we could be contaminating a healthy water bottle. What's wrong with this picture? See the red arrow? I see dark. I see black. This is a contaminated water bottle. Bleach will not prevent this growth. It's embedded in the plastic. So we need to order a new bottle and a new uptake straw. Now, look at this bottle on the upper right photo. That bottle is green where it shouldn't be white. This is a gross biofilm on this used water from the Statum. Now that water in there is contaminated because it sterilized all those instruments, and it's inside that bottle. So I don't know how often they clean their bottles, but any person that would be emptying this bottle needs to wear the correct PPE, which would be gloves, masks, and eyewear. Just think of what's growing in that green bottle, and it will need to be replaced. So you don't want to just dump that bottle out without any protection. You don't know what's growing in there. Infectious, oh yeah, observe the color of the straw. We need to test for the water health. Don't assume, but you should know what your CFUs are, just like we should know what our blood pressure is. Strategy number 4 is manufacturer's directions. Well, we need to collect the written protocol from the manufacturer, and for the unit and for the product. I suggest you laminate it and make it infection control friendly. Keep it in the OSHA manual. Keep it convenient for all. You might want to keep it in every room. The CDC and the ADA have not put together a step-by-step protocol for water lines, but we're attempting to do that tonight. We have current waterline products that are classified as independent reservoir systems, chemical or germicides or cleaners that inactivate or remove biofilm. We have chemical germicides or cleaners that prevent the attachment of biofilm and are of continuous treatment. We have slow-release resins or metered devices that prevent biofilm attachment. And we have bottled water conditioning systems as filters, UV, that do not affect the biofilm directly. So you really need to know what you're purchasing. And I certainly can't tell you what to purchase or what's the best because every office is different. We have chemical treatments that are liquid or tablet. We need to either remove or inactivate the bacteria. These products may not result in delivery of healthy water should the water pass through the water lines containing biofilm. So you could be putting all the distilled, healthy water you want through in your bottle, but if those tubes are all filled with biofilm, it is contaminated by the time it gets to your patient's mouth. So you really need to think about what you're using and consult the product directions so that that doesn't happen if your water lines are treated on a routine basis. Then we have filters. They treat water at the point of use. They're municipal water usually, but filters must be replaced periodically, and the frequency will depend on the bacteria and the biofilm within the lines. Filters may not remove endotoxin, and filters do not affect biofilm. They just remove some of the calcium and the contaminants coming through the water prior to going into the dental unit itself. Now we have poll number 3, and poll number 3 is going to go up. I'm going to launch that poll. We have 15 seconds. When should a facility test the quality of their water lines? Okay, I'm going to go ahead and close this poll. All right, great. All right, when should a facility test the quality of the water lines? It should be quarterly. That is what's recommended by the United States Air Force, is to test our water lines quarterly. The CDC recommendations are flush the lines for 30 seconds. This only temporarily reduces the microbes, and it does not replace using a product or shocking treatment. The air, water, and the hand pieces for 20 seconds after each patient and to prevent the retraction of the fluid. And do not use the dental unit water for any procedure that involves surgery or cutting of the bone. That all needs to have sterile water. And this is a single-use only sterile water bottle. It is 1,000 milliliters. And if you don't feel you'll use that much during a surgical procedure, you cannot reuse it on the next patient. This is a single-use only. Strategy 5, integrate the routine training. We want to formulate a plan. We want to have an annual training, a scheduled training, show and tell, and a signature of the trainee. We want to make sure everybody is aware of how to maintain your water lines. Then we have the standard operating procedures that are written, available to the team, and convenient to all. So the to-do list is you want to have possibly a plan formulated by November 12th, and then a checklist, and then a baseline test, then training, and then have healthy dental unit water lines. Before you purchase, to prevent buyer's remorse, I suggest you get on the internet and find your safety data sheets. Now, material safety data sheets are no longer called that. The OSHA has changed it to safety data sheets for the hazardous communication plan. So there have been a lot of changes in OSHA. So if you're not aware of this, you might want to talk to your trainer, but you need to keep up with the trainer and the coach. And if you don't have a trainer or coach, please feel free to contact me to determine what your needs might be. But you want to make sure that your products don't have limitations to your staff. You want to make sure everybody's on the same page and is willing to go ahead and maintain the water line. You want to research the SDS safety data sheet for health and safety and for any human or pet hazards. So beware. Strategy 6 is scheduling a waterline maintenance. You want to do this quarterly. You want to test all the rooms at once. You'll probably make somebody's life easier, your OSHA coordinator and for the team. And you want to make sure that everybody's trained and doing it properly. So have all those standard operating procedures out, step-by-step instructions. And OSHA Training Bootcamp.com has record keeping for all maintenance. And you can see my website. We have a couple manuals for your convenience to maintain a lot more than the water lines. There's a lot more equipment that behind the scenes that needs to be maintained. And so I have put together some record keeping to make your life easier. Share with the patients. To ensure safe water standards, all clinical staff members should be educated about dental unit water quality, the biofilm, the water treatment, and the dental unit maintenance, including monitoring the water quality. We should feel free to discuss this with our patients because who knows if they have heard on the news about the 82-year-old woman that passed away from being at their dental office. Who knows what they understood or didn't understand. So we need to be in the know. We need to show off our certificates if you receive one. Don't create your own. And then you want to frame it for viewing. State of the art, it's not just a smile that walks out the door. It's also behind the scenes. We have our ammunition. We're reducing risks. We have the knowledge. We're caring. We're skillful, we have support, we have the products, and we have the water certification. We have everything we need for healthy water lines. We have disposables are in and are much safer because it'll prevent cross-contamination. We know we cannot clean the metal syringe tips. It is highly recommended to use disposable syringe tips, and they're a single use per the CDC. And Total Care has made that happen. What's available? Well, we have tablets, liquids, cartridges, filters, and UV light. What works best for your team and for your practice? If you have a very large practice, you might want to go into cartridges. If everybody's on board, you might want to keep with what you're doing or using tablets or liquids. But all in all, you need to find out what's good for your team in your practice. We have Sterisil that has a bio-free tubing and bottle. And they have Citrasil, which helps during patient care. We have Citrasil Shock that helps shock the lines before you start any tubing and bottle. And then we have the tubing and the straw that work together for a year. And then Sterisil has the cartridge. And that's the Sterisil system, which is a UV, a filter, and has yearly maintenance. We have Hufridi that has Team Vista, and Vista Clean is an irrigant to maintain water health, and it's also used during patient care. Then we have Vista Tab, which is a shock cleaner, which is used monthly or more, depending on your water quality. The only way you're going to know about water quality is by testing your units. We have Macrylium that has an antimicrobial xylitol chlorhexidine-based liquid. It is light blue. One time they recommend once a week for shock and cleaner, and then sometimes left overnight and then flushed. You can also use this during patient care. It's a continuous maintenance, and it has a mint flavor to it. We now have DentaPure, which is has an uptake straw directly into the unit. It's used during patient care. It treats about 240 liters of water, which is approximately 1 year's worth. It does meet the ADA and the CDC standards, and you can use tap water. And below we have an installed plumb unit, which is a cartridge for municipal water supply. The good, the bad, and the ugly. The good, that we are aware of the risks, and biofilm can be controlled. We have it under fire. There are many great products available for all dental practices. Advertising your water quality will be a great referral source. Keep the certification at the front desk. The ADA, the CDC, and the health department are all over patient safety. Also, be sure that your team is up to date with all the changes in infection control and the use of new products, such as disinfectants. The bad, people are dying from disease in dental offices with the water lines, specifically Legionella. As an oral health care professional, we can fight this battle. Are we ill because the water aerosols that swirl around our rooms? The ugly. People are aware of this danger in dental offices. Could this be why they are not returning? Or could it be the observation of infection control protocol that is not accurate and they know it? So be aware of what's going on with your team and that they are up to date with all their infection control practices. We've monitored manufacturers' directions. We've gone through all of it. We have Waterline Health. Congratulations. If you have any questions, please send them forward. And here is my saying for the evening. Success is not the key to happiness. Happiness is the key to success. If you love what you're doing, you will be successful, per Albert Schweitzer. Any questions, please send them my way. Also, you can also email me any questions that you have. I want to thank you for taking the time for this very valuable webinar, and I hope you've learned a lot that you might be doing or you might want to fine-tune your protocol. So also, thank you for joining OSHA Training Boot Camp via the webinar. You can join us and exercise your knowledge. We don't sweat with this boot camp. So we just have fun, and we have a lot of fun learning new things in infection control. I thank you for your time and your professionalism. And please, if you would go to Facebook and like us, I'd greatly appreciate that. And please don't hesitate to send me any comments or questions that you might have. Thank you so much. See you. And oh, don't forget, March, we will have another webinar on dissecting your disinfectants. And so stay tuned. It should be on my website, so you can check back with that. Thank you so much. Have great holidays. Bye.